Welcome. My name is Michael Knudsen, and I'm a shoulder and elbow surgeon with the Department of Orthopedic Surgery at the University of Minnesota. Today, we'll be going over the elbow exam for your Bellringers workshop. The elbow exam begins with inspection. You want to expose and inspect both elbows for swelling, redness, size, external signs of trauma, and carrying angle. A normal carrying angle is between 5 and 15 degrees. Here you can see that the patient's elbows have both been fully exposed, so you can clearly see all of the skin and surrounding tissues of the bilateral elbows. You can compare one side to the other. Measurement of the carrying angle involves bringing the elbow out into full extension and then measuring longitudinally in line with the humerus and in line with the forearm. Again, normal should be between 5 and 15 degrees. Next, we will be assessing range of motion. Normally, full extension is denoted as 0 degrees, full elbow flexion is to approximately 150 degrees, full pronation to 70 degrees, and supination to 90 degrees. The elbow is brought into full extension, and a goniometer should be used for accuracy. Here, the patient demonstrates full extension to 0 degrees and elbow flexion to 150 degrees in this instance. Next, in order to examine pronation and supination, the elbow should be brought to the side and the palm should be turned fully up for supination. And a goniometer can be used again to assess for full supination to 90 degrees and full pronation in this instance to 70 degrees, using the wrist as the landmark. Both sides should be compared to one another to assess for full symmetrical motion. Next, we will be examining elbow strength. This includes flexion and extension of the elbow, pronation of the wrist, supination of the wrist, and flexion and extension of the wrist. All strength should be graded 0 to 5, 0 showing no muscle contraction, 5 showing full muscle strength. First, elbow flexion is tested. Next, elbow extension against resistance is tested. Supination against resistance is tested, asking the patient to turn their palm up. And likewise, asking them to turn their palm down for testing pronation strength, wrist flexion strength, and then wrist extension strength against resistance. Next test is for stability testing. We test valgus stress with the elbow in 30 degrees of flexion. We can test the Melking maneuver and the moving valgus stress test to specifically test the medial collateral ligament. And we can test varus stress to stress the lateral collateral ligament, again with the elbow flexed approximately 30 degrees. So here we show the elbow being placed in approximately 30 degrees of flexion, and then maintaining control of the proximal segment, and then stressing with a valgus stress. The hands are switched, and a varus stress can be applied. Next, the elbow is brought into approximately 70 to 90 degrees of flexion, and then the medial structures are tensioned by pulling the thumb outwards. Pain or apprehension along the medial elbow indicates a positive test. This test can be modified by bringing the elbow through a range of motion. This is called the moving valgus stress test. This is highly sensitive and specific for a medial collateral ligament injury. Next, we will perform palpation of the elbow, including anteriorly of the biceps tendon with a hook test, posteriorly palpating the triceps, the olecranon fossa, and the olecranon bursa. Medially, we test the medial epicondyle, the medial collateral ligament, the ulnar nerve with a Tinel's sign or subluxation, and then laterally for the lateral epicondyle, radiocapitellar joint, and other lateral structures. Here we will start with a hook test. The biceps tendon can be palpated and a finger can be used to hook the biceps tendon. The absence of a hook test is highly sensitive for a complete distal biceps tendon rupture. Next, we're palpating the olecranon bursa, overlying the olecranon, the tip of the olecranon itself, and then palpating the olecranon fossa. Laterally, we can palpate the lateral epicondyle, and then just distal to that, the radiocapitellar joint. You can actually put the radiocapitellar joint between your two fingers and then pronate and supinate, sometimes crepitus, or pain can be encountered in the setting of fracture here. Just distal to the lateral epicondyle is a common source of pain with lateral epicondylitis. The medial epicondyle likewise can be palpated, and then just distal to the medial epicondyle, the medial ulnar collateral ligament can be palpated. The ulnar nerve can be found just posterior to the medial epicondyle. It is usually best to bring the elbow into full extension and then gently try and roll the nerve underneath your fingers. This corresponds to the funny bone. You can gently tap along the course of the ulnar nerve throughout the cubital tunnel with positive numbness or tingling or radiating nerve sensations down the forearm, sensitive for nerve irritation through this area. You can check for a subluxing ulnar nerve by placing your finger over the medial epicondyle and then bringing the elbow into flexion. If the ulnar nerve is subluxing, you'll feel the nerve flip up over the medial epicondyle with increasing flexion. Thank you for your attention.